Insomnia is a fairly common problem. Something like 10% of the population at any time will be having this type of difficulty with their sleep. In terms of the diagnosis of insomnia, there are two main parts to it: dissatisfaction with sleep and impact the next day of sleep problems. So in terms of dissatisfaction, we talk about difficulties getting to sleep or initiating sleep, difficulties staying asleep, waking early in the morning and not being able to get back to sleep, or just finding that your sleep is not restorative. That is, you are getting what seems to be enough sleep, but you are feeling that you haven't had enough sleep. And so it's those two problems. So that's the dissatisfaction. And the negative impact is where I'm not able to do the things I would normally do, working, parenting, whatever it is, without distress and anxiety and mood problems the next day. And these two problems, the dissatisfaction and the impact on mood next day, have to occur in the context of sufficient opportunity to sleep. That's when we call it insomnia. If I'm not sleeping because I've got a young baby and they're waking me all night long and I'm having these two experiences, that's not insomnia. Like 10% of the population are in this ballpark. One of the things that we now think about with these sort of diagnoses is they're not really categorical. It's not so much you have insomnia or you don't have insomnia. People have varying degrees of it. And so the current diagnostic system encourages us to think about not just whether someone has insomnia or not, but how significant it is.
Insomnia generally gets worse as you get older, so the incidence of insomnia gets greater the older you are. The older adults over 60, 65 probably have more incidence of insomnia. You're probably looking at around about a quarter of people, maybe a fifth to a quarter of people over 60, 65 who experience insomnia.
Yes, there are big individual differences. So 8 is sort of the average for adults, but often we'll speak to adults and some will say I'm fine on 6, 4, 2 hours sleep a night. So it's not the amount of sleep, that is not the variable we're talking about. 8 is the average, but some people need 10, 11. Younger people, adolescents and children of course, do need 10 or 11. Psychologists think about it, and this is the way most people would understand it in terms of treatment, is we could think about predisposing, precipitating and perpetuating factors, what we call the 3 Ps. So predisposing factors, things that make it likely that you might suffer from insomnia, might be you might be a bit of a worrying person, you may have a stressful life, you may not have enough time to relax, you may not have skills around sleep, so you may have some very bad habits around sleep. So that predisposes you to have problems with sleep. And then the precipitating factors could be life events or something acute that happens to you that actually causes you to have some difficulties with sleeping. So you might have some stress at work, or have to get up early to travel to Sydney to do some work, or some life event that triggers some problems with sleep. And for people who are predisposed to insomnia, that life event might get them into a bit of a cycle of bad sleep. And that's what we call the perpetuating factors. That is, you might start to worry that you're not getting enough sleep. You might start to avoid bed. You might start thinking, every time I go to bed I can't sleep, I'm going to stay up later and later, so I'm so tired that you'll do things that actually become perpetuating factors. They're actually making it worse. And so the psychological or behavioural therapies for insomnia actually target those perpetuating factors. What is it that you're thinking and doing that's keeping the problem in place? And there are very effective psychological interventions that target what you're thinking about sleep and what you're doing around sleep and daily activity that is keeping that problem in place.
Sometimes you do need medication to help. The problem is those medications are addictive, so can be addictive. There's also behavioural therapy, or cognitive behavioural therapy is what we call it. and often in terms of treating someone, you aim to get them self-managing the cognitive behaviour aspects of their sleep by after about between 6 and 12 sessions. If it's an ongoing thing, they may need to come back and see you again and again, but by the end of the 6 or 12 sessions with the psychologist, you hope that you've given them enough practice and enough information in order for them to self-manage their insomnia. But some people will still need medication, but as psychologists, as you're probably aware, can't prescribe medication. That has to be done by a medical professional. Insomnia doesn't have that strong a genetic basis. It's generally what you have is someone who perhaps is vulnerable to sleep problems, and then superimposed on top of that are environmental and behavioural things that are going on, familial things that are going on in their family and their environment that increase the chances of them actually having insomnia.
Worrying about things across the day, particularly worrying about your sleep. So one of the rules that we tell people is after dark, you shouldn't be thinking about any problems you have, that you will not, you won't process problems very effectively. You worry and ruminate about them, and that's definitely the case once we're in bed. Once we're in bed, we should not be trying to problem solve. In fact, one of the rules of what we call sleep hygiene, which is a sensible approach to getting good sleep, is if you're in bed and you haven't gone to sleep after about 20 minutes, is you must get up. You don't lie in bed trying to go to sleep. One of the few things that we know keeps human beings awake is trying to go to sleep. Sleep is a process that has to happen, as it were, passively. We can't make it happen. The more we try and make it happen, the more elusive it is. So these are some of the simple steps that we can do to try and break a habit of poor sleep.
Yeah, well, there's a lot of things. Caffeine is a stimulant, of course, which can make you feel more awake. So anyone who's experiencing insomnia, we would recommend no caffeine after a certain period of time in the afternoon. So it's not, if they're going to bed at 11, they need an 8-hour period before their last coffee. It's using mobile phones and iPads before bed. This requires a little bit of understanding about how the sleep system works, but the blue light that's emitted from these devices, these portable devices, actually can suppress the chemical in your brain called melatonin, the hormone in your brain called melatonin, which actually makes you sleepy. So the blue light is telling your system it's daytime, it's time to stay awake. So we would definitely recommend that people who are using technology at night, particularly those portable technologies which are kind of self-illuminating, we would say don't use them prior to bedtime because it's not allowing your system to wind down. The other big one that people do to help them with their insomnia is alcohol. A lot of people with insomnia self-medicate with alcohol. And what we've found with alcohol is that although it makes you feel drowsy, and it does help some people get to sleep, what it stops you doing is getting the deep sleep that you really need. So again, that's another complicated issue that you need to speak about with the client about stopping the alcohol and finding other ways of winding down.
The best practice treatment for sleep problems in any age group is not drugs, it's the psychological and behavioural therapies. That is, people can learn the skills to treat their own insomnia, and medication is not the best first line treatment for insomnia.